Okay, thank you. So the background is that even in stage 1 and as we move on from stage 1 to stage 2 and stage 3, in spite of surgery, we have high local and distant relapse, and the majority it is distant failure rather than local failure. Most of the failure occur within 2 years, and with available perioperative chemotherapy, we can improve survival by 5 to 8%. So we can see that 5-year survival for stage 2 is around 50%, and for stage 3 it is around 25% with surgery alone. So we definitely require something more on it. We added chemotherapy. We could improve survival by 5 to 8%, but not beyond that. So we always needed something more than chemotherapy alone. Next slide, please. So I will first go through CheckMate trial. Can you help in changing the slides? I'm not able to do it. So CheckMate trial, it was newly diagnosed resectable stage 1B more than 4 centimeter, 2 stage 3A NSCLC patient, performance status 0 to 1, no EGFR and ALK mutation. They were stratified based on stage 1B2 versus 3A, based on PDL1 status less than 1% versus more than equal to 1%, and male and female were stratified. 1:1 randomization to Nivo 360 milligram every 3 weeks with chemotherapy versus chemotherapy alone. Radiological staging after 3 cycles, and surgery was done within 6 weeks of completion of 3rd cycle. Adjuvant chemo and radiation were optional, and then patient were followed up. Primary endpoint was PET-CR and event-free survival. The secondary endpoints were major pathological response, overall survival, time to death or distant metastasis, and exploratory analysis was EFS by PET-CR status. Next slide, please. So the baseline characteristics in both the arm, Nivo plus chemo versus chemo, was similar. We have a good number of elderly patients more than 65 years of age. Performance status 1 patients around 31%, stage 3A patients around 60%, squamous and non-squamous again around 50% in each arm. So again, as per PDL1 status, more than 50% was around 20 to 25%, 1 to 49% was around 28% in Nivo chemo and 26% in chemo arm, and less than 1% was 7 patients in either percentage in either of the arm. Next slide, please. So in the Nivo chemo arm, around 83% of the patient, 149 out of 176 patients who received treatment underwent surgery, and in chemo alone arm, 75% underwent surgery. And post surgery, around 3% patient have received chemo or radiation, chemo and radiation. 5% have received radiation alone, and 12% patient have received chemo alone in Nivo chemo arm, and 22% have received chemo alone in chemo arm. So around 94% of patients completed neoadjuvant treatment in Nivo chemo arm and 85% in chemo alone arm. Next slide, please. So 2 important point: the surgical rate was not decreased by adding nivolumab, rather it was bit better numerically. Second important point, pathological complete response was 24% with Nivo plus chemo versus 2% with chemo. So based on these 2 data, we all were already excited about neoadjuvant immunotherapy. Then we have event-free survival data. Now this data at median follow-up of around 21 months, we have median EFS of 31.6 versus 20.8 months with hazard ratio of 0.63, a very significant p-value, and confidence interval not crossing unity. At 2 years, 64% versus 45% of the patients are without progression or death. Next slide, please. So once we know that we have benefit in event-free survival, so in all the subgroup analysis, there are some subgroups which are important to see. If we compare stage 1B, stage 2 versus stage 3A, the benefit looks more in stage 3A. Stage 1B2, the line is confidence interval line is crossing unity. Again, when we see PDL1 status more than equal to 50%, beyond doubt it is benefiting with addition of Nivo, as we see in metastatic setting also. 1 to 49% patients, the confidence interval line is just crossing unity. Less than 1% patient, it is much closer to unity. So when we are considering giving treatment, especially patient has borderline finances, then this subgroup analysis is something which we can consider in selecting the patient. Next slide, please. So as I told, based on subgroup analysis, also here we can see that based on baseline stages, in stage 3A, the hazard ratio is 0.54, not crossing unity, with median EFS of 31.6 months versus 15.7 months. While in stage 1B and stage 2, hazard ratio is 0.87 and confidence interval is crossing unity. And the Kaplan-Meier curve, the separation is not as good as what we see in stage 3A. Next slide, please. For PDL1 expression less than 1% and more than 1%, again, for patients with more than equal to 1%, hazard ratio is 0.41, while for less than 1%, it is 0.85, and the confidence interval is crossing unity. So the quantum of benefit in more than equal to 1% looks clearly significant compared to less than 1%. Next slide, please. And when we compare it between 1 to 49% versus more than equal to 50%, the obvious benefit is maximum with more than equal to 50%, where hazard ratio is 0.24. And at 2 years, you see 85% without progression or death in stage 2, 3A and 1B patient, which is commendable. While that quantum of benefit is not clearly seen in stage in PDL1 1 to 49% of the patient, still the hazard ratio is 0.58. Confidence interval is just crossing unity. Next slide, please. So squamous and non-squamous both derives benefit, but the quantum of benefit looks more in non-squamous patients. Based on hazard ratio and confidence interval, we can see that, and even the separation in Kaplan-Meier curve is evident. Next slide, please. So one more finding which we see in many neoadjuvant treatment and even in many immunotherapy, that patient who achieved PET-CR, the prognosis of that patient is much better than the patients who have not achieved PET-CR. So this is the clear-cut separation between patients who achieved PET-CR and not achieved PET-CR. The median event-free survival was not reached in PET-CR patient, and the hazard ratio was 0.13, which is really significant. Next slide, please. Overall survival is still not mature, but there is early separation. We are still not in a condition to comment on it, but this is something which been. Next slide, please. So once we have efficacy, the next important thing is what are the adverse events. So based on the previous slide, we can see that adverse event looks similar in both the arms. There is no increase in toxicity or inability to do surgery by adding immunotherapy. So in summary, for Checkmate 816 addition of nivolumab, there is clinically meaningful improvement in event-free survival. The preliminary OS seems to be trending towards nivo plus chemo, but still it is immature. Event-free survival in patients who achieved PET-CR is much better than and looks like an early indicator for therapeutic benefit of nivo plus chemo. Safety profile is consistent with previous studies, the phase 1 and phase 2 studies in neoadjuvant setting, and it is not deterrent to surgery. So that is also something which we need to keep in mind. So Checkmate 816 is first phase 3 study with neoadjuvant immunotherapy based combination, which have shown improvement in EFS and PET-CR, and we are awaiting overall survival result. Next slide, please. So Nadim 2 is a similar study where nivolumab plus peglycarbo was given and a control arm was peglycarbo. The patients in this study were only stage 3 and stage 3B. It is a phase 2 study, and adjuvant nivolumab for 6 months was allowed in this study after surgery. So there is some difference in design between these two studies. Next slide, please. So again, only 4 patients out of 57 were not able to undergo surgery in Nivo plus chemo arm, while 9 patients out of 29 were not able to undergo surgery in chemotherapy. Next slide, please. The baseline characteristics were well matched in both the study group. Next slide, please. The patients undergoing definitive surgery was 93% versus 69% with Nivo plus chemo versus chemo arm. Next slide, please. The PET-CR rate was 36.8% versus 6.9% in intention to treat population. Significant leap in PET-CR rate. Next slide, please. Major pathological response was seen in 52.6% versus 13.8%. Again, a major benefit. Next slide, please. Overall response rate was 75.4% versus 48.2%. Next slide, please. Adverse event, there was some increase in adverse event from 10.3% to 25% by addition of nivolumab, but the number of surgeries were not low. So there is some increase in toxicity in this group of patients, but we are able to do surgery and we are able to get a good pathological response or PET-CR rates. Next slide, please. So if you compare the toxicities, the grade 3 and grade 4 toxicities were a bit more in nivolumab arm. But if you go through the toxicity, it was fatigue, which was more. There was more febrile neutropenia, the grade 4 toxicities, and some transaminitis, which was more. So maybe that is something which we can manage or which is temporary. Next slide, please. So Nadim 2 is something like a confirmatory trial, which we got a hint from Checkmate 816. And we know that addition of nivolumab even in stage 3A, 3B patient improves PET-CR rate, improves major pathological response, and has a tolerable safety profile and does not deter us to doing surgeries. I think this is the concluding slide. Next slide, please. So now, are we ready for neoadjuvant treatment in currently upfront? So for me, I'm excited. I will await for overall survival benefit for someone who is having high PDL1, 4 cycles or 3 cycles of immunotherapy before surgery is something which excites me. We get a good pathological complete response. For adjuvant trials, we have different results with pembrolizumab and atezolizumab. One trial is saying that benefit is not there in less than 1% of patients. The other is saying it is there. Pembrolizumab is not showing benefit in more than PDL1 more than equal to 50%, which again is surprising. There is a theory that because in neoadjuvant we have sufficient neoantigens because we have cancer in vivo at that point of time. So maybe neoadjuvant is a better idea. Tolerance, obviously, as we see in most of the treatment, neoadjuvant is tolerated better than adjuvant. So maybe excited about it. I'm awaiting OS benefit, but in the patients who are eligible, I think this is the last slide. So if there is any question, we can take. Thank you.
Dr. Rushabh, thank you so much for your presentation. I think giving neoadjuvant treatment with immunochemotherapy increases PAT-CR rates quite a lot, and in PAT-CR they are associated with increased EFS. But there is some concern, I think, about adverse events since the tumor is still in situ and there is and unlike stage 4 disease when the tumor has a immunoexhaustion kind of environment. There is no immunoexhaustion kind of environment here, and there is increased some amount of increased adverse event. Similarly, I think we also have spoken to some of the surgical colleagues who say that once you have neoadjuvant immunotherapy, there is a lot of tumor fibrosis and inflammation, after which the surgery becomes really difficult. And there is the clinical trial with atezolizumab resulted in almost 40% more of open thoracotomies as they were not planned. So patients, they have to be shifted from VATS towards open thoracotomy. So there are really some challenges with this. The real tumor marker, whether you need to have double immunochemotherapy with nivo plus ipi or single agent nivolumab is sufficient for how long, whether it should be given neoadjuvantly followed by chemotherapy, or you should be giving immunotherapy. Because if you give immunotherapy as a neoadjuvant treatment and then you start giving chemotherapy as an adjuvant setting, lymphodepletive, immunosuppressive, you may lose what you have achieved in the neoadjuvant setting. So, do you think that this trial is a practice-changing trial?
So, so it is still early to say that we will in all the patients. But if someone is having high PDL1, I would be tempted to give. That is what the message is. We will surely we need to await for overall survival. We still are not sure. We have different results with different trials.
Yes,
and even the
LCM
toxicity rate is different.
Right. Very true. So with LCM M3 trial with atezolizumab, I think 10% patients have become inoperable once they were given immunotherapy as a neoadjuvant setting. So we have to be careful that our patient may progress as well.
Yeah. So these studies, that atezolizumab, durvalumab study, and even the nivolumab, ipilimumab study, I think they are with lesser number of patients and phase 2 studies, most of them.
Right.
Checkmate is probably the one with maximum number of patients. And if adding nivolumab is not going to increase your patients who are not going to be operated, then I'm still okay. But the atezolizumab study was something which was worrisome. So if you're not able to operate a curable malignancy just because you added some drug, then that is something which we need to consider. But I think IO plus chemo would be something which will come with some benefit, because the proportion of PET-CR and major pathological response, the increase in that we are seeing looks clinically meaningful.
So you see in that NeoStar study, there was immune flare in up to 11%, 15% of the patient in lymph nodes, and they were labeled as unresectable. So this might be a risk that surgeon may avoid doing a curative surgery in these patients just because of the patient had increased amount of tumor fibrosis and inflammation.
Again, adding ipilimumab would again lead to some increase in toxicity.
Right.
So that is something also which we should consider. So as of now, from the available study of durvalumab, nivo, ipi, atez, and nivolumab, I think nivo plus chemo is something which has the most promising data as of now. I think if we get overall survival benefit and if it can be replicated in majority of the centers, then that is something which will tell us to change the practice. Till then, we need to wait for some time.
We have Dr. Sajjan sir here. Dr. Sajjan, your comment, please, on neoadjuvant immunotherapy before we start your session, sir.
So, Dr. Manisha, I've been listening to both of you, and I think both of you have valid points. I think it needs more time for us to actually understand which is the best agent to combine in the neoadjuvant setting. So with the data which are shown with this checkmate trial, I think this looks like a more promising one. And the concerns with atezo, because I think though we understand that all the drugs are PD-1 or PD-L1 inhibitors, but still all of them have different ways by which they interact in the tumor microenvironment. So each drug should be evaluated in a manner, and also once we start using them in our own clinical practice, I think we'll become more wiser.